So next up we have Anthony Hobson, who's Clinical Director at the Functional Gut Clinic. So Anthony studied at University of Manchester, has an MPhil in clinical physiology, and subsequently got a PhD there. So he's been involved in wide-ranging experience across the NHS and private healthcare sectors, as well as academia and pharmaceutical industry, assessing gut function from top to bottom. So this spans conditions such as reflux disease, IBS, fecal incontinence, and constipation. So Anthony's industrial experience includes designing and implementing clinical trials to test experimental approaches and novel treatments in conditions such as IBS, an area he has particular interest in. So Anthony's talk title is Digestion, Fermentation, and Function, using breath analysis to assess digestive health. Thanks a lot, Anthony. Over to you.
Hi, my name is Dr. Anthony Hobson. I am a clinical scientist and clinical director of the Functional Gut Clinic in London. Just like to start by thanking the organisers of the conference for inviting me to talk about digestion, fermentation and function using breath analysis to assess digestive health. So digestive health is a huge area. If we look at the scale of the problem, the prevalence of benign gut disorders such as irritable bowel syndrome or gastroesophageal reflux are 10 to 25% of the UK population. If you look at things like digestive health product market in the US, things like probiotics, prebiotics, enzymes, this is now worth an amazing $32.7 billion per annum and is growing at about 7% a year. Now, the cost to the NHS of conditions like IBS is also significant, with primary and secondary care costs being well over £100 million per annum. Unfortunately, there's still poor evidence of efficacy of treatments for digestive health conditions. There's poor patient outcomes. People are often told they have symptoms for life. And it's a poor show all around. And what I'm hoping over the next few years is that we can really show that we can do better in this area, increase the science, and really help patients and reduce healthcare costs. So the Functional Gut Clinic was established on that basis back in 2013. We're now the UK's leading independent provider of clinical GI diagnostic testing. We have an active clinical trials program, and we have an active R&D program to assess both diagnostics and ingestible products. We're also involved in biomarker development so we can improve the objective outcomes of our studies. And we use state-of-the-art technology and diagnostic algorithms to achieve optimum patient outcomes. Now, breath analysis to assess digestive health has been around for decades. One of the commonest things that we do is gastric emptying. So we want to see how meals transit from the stomach to the small bowel. But we can also look at fermentation via looking at hydrogen and methane breath testing, which gives us insights into things like small intestinal bacterial overgrowth, carbohydrate malabsorption, and cecal malfermentation. You can also use breath testing to look at Helicobacter pylori status and liver and pancreatic function, although I'm not going to cover that here. What I am going to cover just towards the end is how the existing breath analysis paradigm can be improved using new techniques such as VOCs. So the Functional Gut Clinic has 5 areas of primary focus. They are ingestion, digestion, transit, fermentation, and behavior. And we particularly pay interest to both the stomach and how things get from the stomach into the small bowel where they are digested, and then where those waste products go to and how they're fermented in the proximal colon. So the guiding principle for us is that no single test is perfect. Biomarkers are best interpreted in the context of function and symptoms and what's important to the patient. Identification of specific biomarkers is one step in this process, but it's equally important to consider their functional consequence and their underlying mechanism, what produces these biomarkers and what influences them. We always like to assess biomarkers in both static and provoked states. And engagement of your brain is key. You have to put these findings in the context of what's happening with the patient. I think this combination enables us to optimize treatment strategies, and biomarkers really need to influence decision-making to be useful. So on that basis, if we look at a common condition in digestive health, one of gastroparesis or slow gastric emptying, The problem with gastroparesis is many things cause it. It can be related to diabetes, it can be neuropathic, it can be myopathic, it can be due to pyloric outflow obstruction, so an obstruction leading from the stomach into the small bowel, and it can be due to the opposite, so a loose at the top end of the stomach and hiatal defect and reflux. It can be idiopathic, which just means we don't know what's going on, and it can be behavioral, so sometimes patients do things that make their gut function abnormally. It can be drug related, it can be nutrition related, and as you can imagine, how do you decide how to treat that just on the basis of simple biomarker observation? So, what we're trying to do here is look at the stomach in the different phases of emptying. So, fasted, the stomach is collapsed. Once you ingest a meal, the top part of the stomach or the fundus relaxes to accommodate the meal, and then the meal is slowly transitioned down into the midsection of the stomach where it's ground up into a paste and emptied into the small bowel. And this requires appropriate pyloric function, but also an intact hiatal complex at the top end to make sure that grinding is efficient. So at the moment, we use carbon 13 octanoic acid or carbon 13 acetic acid as substrates to measure gastric emptying. We take baseline breath samples, ingest the meal over 2 to 5 minutes, and then subsequent breath samples are taken every 15 to 30 minutes for 4 hours post meal. As the meal is digested, the carbon 13 is absorbed into the bloodstream and excreted through the lungs, and this is detected by dynamic infrared spectroscopy system, which is an office-based system. Now, this is the kind of graph that we get from a gastric emptying study. We look at two main measures, T-lag, which is the point at which you get maximum excretion of the carbon 13, and T-half, which is where half of the substrate has been excreted. And you can see this is a patient typically with dyspepsia, bloating, regurgitation, and they've got borderline abnormal findings. So they've got a T-lag of 55 minutes and a T-half of 88. So you've got a patient, you've got a biomarker, you've identified they have gastric emptying issues. Where do you go next? So the clinician will then say, well, is this behavioral? Is it medication related? Should I give a prokinetic drug to speed up emptying? Should I dilate or Botox the pylorus to encourage outflow from the stomach? Should I perform a hiatus hernia repair to try and prevent reflux? In extreme cases, should they be referred for gastric electrical pacing or even perform a gastric bypass? The alternative is just to manage symptoms conservatively and see what happens over time, and that doesn't usually end in good patient care. So if we just look at the behavioral issue, I won't spend a great deal of time on this, but this is an esophageal manometry recording, and the fiery colors are pressure recordings from the esophagus showing peristalsis, and the purple at the top is showing liquid both being swallowed and being regurgitated. And in this behavioral condition called rumination syndrome, what patients tend to do after a meal is to increase the pressure in the stomach. You can see here, this orange is people straining their abdominal muscles. This creates retrograde pressure pushing up the esophagus. They then regurgitate the food, which is the purple, and then they swallow again. Hence rumination, which is what cows do. But people do this on a repetitive basis, and this can become really troublesome. And this obviously affects gastric emptying, but actually what this patient needs is not surgery or medication. They just need a little bit of behavioral therapy. And what we can do during the meal and after the meal is get them to relax their abdominal muscles, do some diaphragmatic breathing, increase the pressure in their lower esophageal sphincter through this process, and don't do the straining behavior. And they can visualize this on the screen. So this is a good example where we've taken a biomarker measure that's identified slow gastric emptying, but this is something that can be remedied by the patient themselves rather than going down a further medical or surgical route. Now we can also get further information using electrogastrography. So this is like doing an ECG of the stomach. And this can tell us whether the nerves in the stomach are working properly and whether there's any evidence of things like outflow obstruction that could guide therapy. So again, what we're doing, we're taking a biomarker and we're adding on other diagnostic tests to build a picture that allows the clinician to design the treatment. And what EGG has been done, we take those patients with gastroparesis who've been identified as having slow gastric emptying, we do a simple EGG on them, and this allows us to subclassify them and then guide treatment, whether it's pyloric therapy, whether it's treating reflux, whether it's giving a prokinetic, or in the worst case scenarios where you just have to manage symptoms or go on for surgery. So it's not treating the biomarker in isolation, it's using it in the context of other diagnostic tests which help build the picture. So moving on to digestion and fermentation, what this nice slide shows is at the bottom you can see there is the increase in microbial density from 10 to the 3 in the proximal small bowel down to 10 to the 11 in the colon. And you can see that most of the food and nutrient particles that come down the small bowel get absorbed before they reach the colon. And then those more difficult to digest compounds are fermented in the colon, and the microbes produce all sorts of different chemicals, and we get lots of benefit from that most of the time. However, if that bacterial community is not working properly, then dysbiosis is diagnosed. So this is a dysregulation of the microbiome. And this can have quite drastic effects on health. And not just health within the gut, but also it has effects outside the gut, whether that's with metabolic disease, whether it's with immune function, whether it's with mental health issues. So if the microbes inside us are not happy, they can cause a whole host of other issues. So this is why it's vital to understand what's going on and maintain good microbiome health. So where is most of the action taking place? Now, it was only about 7 or 8 years ago that I actually started paying attention to the proximal colon. It's really difficult to get to. We didn't really know what was going on. It didn't really appear to do much apart from when your appendix blows up. But what we've realized now is this is like a second stomach down in the nether regions. And just as the stomach misbehaves in some ways in reflux disease or in gastroparesis, so the C can be the same. And added on to that, it's full of microbes, it's full of chemicals, it produces all sorts of things. And it's this chemical production plant and fermentation vat that sits within us that I think is going to be the most interesting area to interrogate over the next 5 to 10 years. So how can we do that? Well, the first way we got to do this was with a capsule called Smart Pill. So it measures pressure, temperature, and pH. You swallow it and it wirelessly transmits that information to a receiver. And whilst most people are concentrated on transit times and gastric emptying, what we were interested in was this region here, which represents the interface between the distal small bowel and the proximal colon. And what you get here is a drop in pH of usually about 2 units. And what this drop in pH is due to is the fermentation and production of short-chain fatty acids. So it's a biomarker of fermentation in the proximal colon. Once we were happy that this was the case, then we were able to show that in patients with irritable bowel syndrome, the drop in pH across that junction was much greater, and this correlated with symptoms compared to healthy subjects. So these people were getting the same test meal, but this was being excessively fermented by their microbiome and causing all sorts of havoc in the lower GI tract. Then we were able to put that to see whether therapeutics work, and the best treatment for this at the moment has been the low FODMAP diet. And what we were able to show was that after 28 days on the low FODMAP diet, we could normalize the cecal pH. And this must be due to changes in the microbiota because the same test meal was used and it correlated with symptomatic improvement. So all of a sudden, back in 2017, we had a target to go for in terms of proximal colon fermentation. So how else can we look at it? We can look at it via hydrogen methane breath testing. So when bacteria interact with carbohydrates, then they tend to break them down and ferment them. And those fermentation products include short-chain fatty acids, which you can see at the top, but also gases such as hydrogen, methane, and also, on a lesser extent, hydrogen sulfide. But they also produce bioactive compounds as well. It's an old witch's brew of content being produced in that proximal colon. So what happens in the proximal small bowel is little or no fermentation occurs because you have very few bacteria to do that. Most of the food is passed through your acidic stomach and therefore is fairly low in terms of microbial content. However, when all that waste product gets into the large bowel, then bacterial fermentation occurs. Now, if you get too much bacteria in the small bowel, you get SIBO. And if you get the wrong type of bacteria in the colon, you've got colonic dysbiosis, both of which cause symptoms of varying severity. And this is just illustrated here. What you can see is in this schematic that you've got easily digestible foods such as rice being absorbed in the small bowel on the top trace, where poorly digestible starch and beans and things, they go down into the small bowel and through into the colon where they get fermented. And that's just normal for our diet. But if you get an increase in bacteria in the small bowel, then even easily digestible rice starts to be fermented in the small bowel. And this fermentation and putrefaction of food in the small bowel, um, which is very sensitive and small by nature, creates a whole host of unpleasant symptoms. So how do we test for that? What we do is we give different types of sugar, and then we take breath samples and measure hydrogen and methane gases as the bacteria interact with those sugars. Now, SIBO is defined as the presence of greater than 10 to the 3 bacteria in the jejunum as taken out by aspirate during endoscopy. Not a very elegant way of doing things, which is why we use breath testing. But that premature fermentation in digested food and drink produces waste products such as gas and toxins that creates a whole host of unpleasant symptoms. Now, the causes of SIBO include decreased stomach acid, and we've shown that this can be both naturally occurring in terms of achlorhydria and pernicious anemia, but most commonly it's caused by long-term PPI usage. And you also have issues with motility problems, structural issues, and disruption to the gut and intestinal microbiome via infection in particular. We can also pick up methane. Methane is produced by archaea, which are not bacteria, but are very basic organisms that are found at the bottom of oceans and swamps. And methane has the curious effect of slowing down gut transit, making you feel bloated and constipated, and also helping you harvest extra calories from your waste products. So excessive methane production can lead to bloating, belching, flatulence, constipation, but it also can contribute to reduced weight loss after bariatric surgery. One of the other intriguing things about methane is that oral iron supplementation is associated with GI side effects in up to 70% of patients that take it, where these effects are absent if you take iron intravenously. Therefore, there's an interaction between iron and archaea, which it uses as fuel to increase methane. And we have shown that the people who take oral iron have the highest levels of methane that we see in the clinic. So there's a really nice model there of introducing a mineral or supplement, seeing a change in symptoms, and then having a biomarker to try and figure out what's causing it. So the science behind hydrogen and methane breath testing, when we use glucose, what we do is we examine the proximal small bowel because glucose is absorbed in the first third of the small bowel. And therefore, if we do get a positive test with glucose, then it's a very strongly positive test. However, if the bacterial overgrowth is further down, then the glucose is absorbed before it reaches the bacteria, we are liable to get more false negatives. To overcome that, what we can do is a synthetic sugar using lactulose, which goes all the way down into the colon, and we should get a rise in gas production in all people who take this. So if we get a negative response with lactulose, then we're sure it's a true negative. However, sometimes the lactulose moves through the system too quickly and we can pick up false positives. So there's definitely a nuance with breath testing. You have to engage your brain, you have to use common sense. And we always look at things like symptoms and use both lactulose and glucose if we're uncertain. These are the kinds of graphs that we get. So you can see at the top, we just get a small rise in hydrogen and no increase in symptoms. But in a SIBO patient, we get large rises in gas, both in the early stage of the curve in the small bowel and in the second part of the curve, which is the colon. And the patient also starts to develop symptoms of bloating and abdominal pain. So we have a good, strong positive test there. Why is that important? Well, treatments for SIBO include rifaximin, which I think in America is about $1,000 per prescription. In the UK, it's about £300 per prescription. And if you just give this empirically to everyone with IBS type symptoms, you get about a 40% efficacy rate. But if you tie dosing with rifaximin to a positive lactulose test, then you can increase the efficacy of that compound to up to near 70%. So it's just a good way of showing that you have a biomarker of SIBO. you have a treatment for SIBO. If you tie them together, you increase the efficacy. That should improve patient outcomes, and it should reduce unnecessary healthcare costs. So the problem with the existing system is the sensitivity and specificity. This is somewhat down to poor methodology in some studies and also poor interpretation. But now we have guidelines that allow us to do these tests the same way across all hospitals in the UK. And we're hoping that we should be able to increase the sensitivity and specificity of these techniques. But really, they're only going to be as good as they are within their limitations. And what we really want to do in the next few years is move on to the next generation of breath tests that will help us understand that more. Which brings us on to what is making me excited about the future directions in digestive health. And we're all here really to talk about volatile organic compounds. These are the metabolic products of internal and, importantly for us, bacterial functions. And there's thousands of these compounds. So there's a real opportunity to move into this undiscovered country and produce higher resolution breath tests. Now, the interesting thing about this slide, it talks about some of the factors that contribute to the VOC profile. And one of the things that contributes is time since eating. And we've had a bit of fun about this, that actually controlling diet before VOC testing is going to be very important for a lot of the work that you guys do, because you're going to try and reduce the noise in the system. But actually, it's that noise which is going to be very interesting for me, because we want to see what all of this noise is when you give people different carbohydrates, proteins, probiotics, and really look at what's happening in the proximal colon. Now, there is some evidence from fecal samples that there are some differences between control subjects, Crohn's disease, ulcerative colitis, and IBS. So, we're at the very beginning of this journey, but we think that we're definitely going to be able to see some strong signals and differentiate between these different patient groups. And how we're going to start that off is to look at this largest VOC producing system in the body. So you've got this area of the proximal colon, trillions of bacteria, all sorts of different nutrients and compounds that we can manipulate and probe. And we want to characterize that in healthy subjects. So what is the healthy vocome, baseline and active? So we can use probes like Lactulose to look at the stimulated vocome. We want to look for specific profiles in different digestive diseases, and symptoms, so can we differentiate between diarrhea, constipation, and so forth? We want to look at specific profiles from gut regions to reflect differences in the microbiome. So are the signals we get in the first part of a breath test in the small bowel going to be different than what we see in the colon? And does that tell us something about species difference and bacterial overgrowth? And we want to try and manipulate this as an objective marker of therapy, whether that's pharmaceutical, nutraceutical, lifestyle, or just general health and well-being. And in particular, we've got an interest in sports and performance as well. And what we're hoping is that this is going to be an order of magnitude more sensitive and specific than current approaches, but with the caveat that we will only be using this biomarker approach within the realms of our current models. Because the current model already tells us quite a lot about what's going on, and this will be supplementary information that gives us an extra layer of sensitivity. So we can already look at gas production, pH, transit, permeability, stool consistency, we can track symptoms. And circling around all of these different biomarkers that we can measure are all these different interventions that people are putting forward to try and promote gut health. So in summary, we have a preliminary model of digestion, fermentation, and function. We've identified some easy to track objective and validated biomarkers, and novel breath markers will increase the spectrum and sensitivity of this testing model. Interventions can be tested using this model, combining both objective and subjective endpoints, which is really important because there's a high placebo response rate using subjective endpoints in digestive health studies. And really what we're trying to do now, this is our mission, is to try and move digestive health from tertiary care, where we sit at the moment, so that it straddles primary care, so that patients get access to these non-invasive or minimally invasive interventions prior to going for things like endoscopy and radionuclide imaging. Obviously with the appropriate clinical governance pathways in place, and with the mechanisms to escalate care if needed and if there are any red flags. And we think this will result in huge savings in healthcare costs and better outcomes for patients. And the outcomes are the important thing. The outcomes will drive the evolution of the digestive health model. So when we get positive findings, we'll be able to feed those things in. And when they're negative, we can take those out and improve the model. And where we're heading now, I think, is towards the maintenance of health and prevention from illness, rather than the treating of symptomatic flare-ups, which is the model at the moment. So can we implement a treatment strategy for just the general public where you can improve and maintain gut health, and that will prevent a whole host of other illnesses, so that we're not constantly trying to fight fires of episodes of diarrhea or constipation, that we're trying to keep an even keel, and that should help with all sorts of other illnesses, be it from diabetes, metabolic illnesses, and so forth. So our mission now is to carry on decoding gut health, control through clarity. And I just want to say thank you again for inviting me to give this presentation, and I'm now happy to take any questions that you might have. Thank you very much.
Brilliant. Thank you so much for that. That was a fantastic overview. I had one initial question. So we look ahead to the volatile organic compound work. So it seems like there's kind of two broad approaches one could take. So you mentioned that if you look at just standard dietary intake, for instance, there may be interesting VOCs produced there in their own right. So I think in the past, and you referenced it a little bit, some of the volatile fatty acids, for instance. So there's a kind of look at what's being produced type paradigm versus administering specific substrates. So challenge type studies, administer substrates, or even look at the administration of specific exogenous VOC probes, kind of similar to what is done with stable isotope type analysis. Do you have a kind of prediction or sense of where you think the best type of results will come through, whether or not it's these challenge of oak probe type studies or just looking at what's being produced?
I think our first speakers have shown what a challenge is to look at what's being produced just metabolically. I think slightly should be watching slightly enviously of what we're looking at here, because the signal that we're going to pick up is huge. I think you saw from those hydrogen and methane graphs, we're looking at in the breath peaks about 100 parts per million of hydrogen and methane. So they're big signals. And what we can do with the VOC probe is wait until we start to see those breath gases, and then we know we're getting some active fermentation, and then go in at that peak point and start to look at the VOCs that are in there. And I would imagine that the signals are going to be huge. I don't think we're going to get a huge amount of baseline difference. I think we've seen, the problem with things like IBS, for instance, is it's such a heterogeneous condition. You're not going to easily differentiate from healthy controls at baseline. But when you give a substrate like lactulose, which activates all of the microbiota throughout the entire GI tract, that's when you start to see differences. So I think we're going to get most value for our money for doing these using different probes. So to start off with something like lactulose, I mean, there's a huge amount of literature about lactulose fermentation, what it does, what species break it down, what some of the gases and products are. So I think that's the big target. And once we have the big target, then we can make it much more nuanced and start to manipulate things. So yeah, it's I think the advantage we have in digestive health is that I think the signal that we're measuring is going to be much greater than in some of the other more challenging areas that you guys are looking at.
Yeah, no, that makes a lot of sense. So one question from Alexis, can we use hydrogen methane breath test, some other tests for more definitive diagnosis of GERD?
So we've just published a paper in Surgical Endoscopy, which is an American journal, showing that patients who were referred for anti-reflux surgery because of poor response to anti-reflux medical therapy, about 70% of them have evidence of dysbiosis. So either small intestinal bacterial overgrowth or increased methane production, and that methane and that dysbiosis correlates with their refractory symptoms. So actually what happens in a lot of reflux patients is that their initial symptoms of heartburn, chest pain are treated well with the drugs, but then the long-term suppression of stomach acid causes bacterial changes. So the symptoms change from being reflux related to digestive related. So if you imagine that 70% of those patients who are about to have anti-reflux surgery could actually just be treated for their digestive symptoms, reintroduce stomach acid, get them, their digestive tract working again, they won't need surgery. I mean, not all of them will qualify for that, but that's how we're using this for redefining certainly the patient selection paradigm. Every patient who's been on long-term PPIs needs a breath test because often their symptoms that are left are nothing to do with reflux anymore. That initial insult has gone. And in those patients where reflux is still a problem, then they can have the surgery, but you have to treat the dysbiosis as well, because the main symptom after surgery is gas bloat, which is caused by digestive issues. So yeah, absolutely, definitely hydrogen methane breath testing should be part of that diagnostic pathway for reflux.
Thank you. A question from Maurice. Anthony, would you be interested in an enantiomeric composition of some of these VOCs for information about the bacterial interaction with the host?
Absolutely, that is exactly what the next phase of our research will be. We're going to start off with some simple experiments just to try and see what's there, but the real sort of treasure chest is going to be looking at what is generating these VOCs and looking at the different types of bacteria, and we're going to have a rich reservoir of patients and conditions where we can look at this. So start with some simple big steps, but once we have that data, we really want to try and drill down onto what's causing it and what those bacterial changes can be.
Brilliant, thank you so much. I think that's all we have time for. There are a couple of other questions. We'll follow those up just through the Q&A chat function as well. So thanks again, Anthony, for that. That was fantastic.
My pleasure.